session. It's going to be very interesting. We have a case discussion, and we invited two expert panelists here. The first, Dr. Elizabeth Raskin. She's Associate Professor of Surgery at UC Davis, Chief of Colorectal Surgery and Staff Physician at the VA NorCal Healthcare System, and Director of Robotic Surgical Education. And she's going to be providing the surgical perspective in terms of managing complex inflammatory bowel disease. And then we also have Dr. Ryan McConnell from Palo Alto Medical Foundation, providing the gastroenterologist perspective. He leads and has developed the complex IBD program for PANF and providing care for Northern California community. Both have been very involved with medical education, as well as specifically an interest in diagnosis and management of complex IBD. So welcome to both of you. Come on up.
Do we have one of the travel laptops?
Do you guys have extra laptops, or maybe, are you guys going to tag team, or?
We're going to wing it.
Oh, okay.
We've never met before, so.
I can stand here and work the slides.
Sounds good.
So thank you very much for the invitation to come and speak. It was really nice to meet Elizabeth and preparing these talks, and I've learned so much about some of the complex surgical care that she provides. And she gave us two really challenging cases from her practice that you'll see as we go through them. The patients are older, they're medically complex, they both have severe penetrating Crohn's disease, so it brings up a lot of interesting things for us to talk about. So I'll let Elizabeth walk us through the first presentation.
Sure. You want me to come up there as well? We haven't fully figured out how to choreograph this session, but the first is a patient of mine, 74-year-old male, who presented with an acute on chronic kind of abdominal pain crisis. He came to the emergency room and he had abdominal pain for several weeks that was most severe, although he reported pain that had been going on for months, if not years. He had nausea, vomiting, and weight loss. His medical history is significant for a diagnosis of Crohn's, and he in fact underwent an ileocolic resection 50 years ago. And then he said, you know, I was cured, so I didn't need to go to the doctor, didn't need to do anything. And he actually was getting by pretty well until the past couple of years. So he had been on no medications over that 50 years. When we saw him in the emergency room, he was tachycardic, his blood pressure was normal, he had a distended abdomen, it was focally tender in the umbilical region. He didn't have peritonitis, but he was really distended, and we noted a prior laparotomy scar. My residents were saying, we got to go to the OR. He's distended. He's, you know, he's perforated. We got to go. And I said, well, let's slow down. Let's slow down and get some facts and get some labs as well as some imaging. So his lab work came back. White count 21,000, platelets 328, and he was in I think he was in his normal renal function because we had some other labs that suggested his creatinine ran around that area, 1.5. He was clearly malnourished, not only by looking at him, he looked cachectic, but his labs demonstrated that albumin 2.4 and a prealbumin of 8. Lactic acid at the time was 2.3, ESR and CRP, as you see there, 46 and 20. And then we ordered a chest, abdomen, and pelvis CT. I don't exactly know why the chest was ordered initially, because we were most focused on his abdomen. But with those labs, we knew he was somewhat septic, and we knew that he was under-resuscitated. And so we started with that as we got him ready to get.
Before you show the CT, we can make a prediction here. And actually, I'm surprised that this patient made it 50 years from the first resection in his 20s to coming in now at 74 with things that you'll show us on the CT scan. Somebody who needs a resection in their 20s is super high risk for recurrence. And this is somebody who really beat the odds. The second surgery was likely to happen 10, 15 years after the first one without any follow-up and without any treatment. So it's pretty remarkable, and he must be living with quite the amount of obstructive symptoms leading up to this presentation in order to make it 50 years from that first surgery up until now with no treatment for Crohn's. This is sort of a heroic presentation just in and of itself based on the timeline.
Yeah. I would agree, and he looked very malnourished, and so it was obvious that this was not something that just acutely happened over the past couple of weeks, that he'd been slowly, failing to thrive. And his abdomen was really distended. It was a little bit tender, but it gave the impression, at least to me, because I do see a lot of patients with complex Crohn's, that it wasn't something really that acute, that he probably was living with an abdomen that was very distended as he was demonstrating to us. And so when we got the CAT scan, we started to see a variety of things. We saw clearly dilated small bowel. That wasn't just acutely dilated, because we could see the enhancement of the bowel wall. Here you see the stricture, but we saw several strictures. And it's just this saccular appearance of the small bowel really kind of gave us the flavor that this wasn't something that just happened over the past couple of weeks.
Do you have any sense how dilated, any measurement, that one saccular area?
You know what, it was at least 8+ centimeters wide. So I don't know the largest area, but what we saw really looked like a chain of sausages. You saw strictures, you saw dilatation, this real saccular dilatation, and then we see in this slice here that he had microperforation as well as an abscess. And so, despite our resident's initial, call for the operating room, we calmed down and said, okay, this looks like a patient who is septic. He's perforated in a localized fashion, but he's not showing us something that we imminently need to go to the operating room with. First of all, he's very malnourished. So whatever we do, he's going to be at extremely high risk of having a post-operative complication. And then the second question is, what are we going to do? What exactly is the plan? And it's not the best thing to go in urgently to an abdomen like this. He's been operated on before, albeit 50 years ago, but we're seeing an extremely complicated picture here. So we had to think, where do we start? And clearly that was resuscitation and antibiotic therapy. His CT of his chest was done, and I can't remember why it was done initially, but he does have a history of Mycobacterium avium. So he had this chronic pulmonary condition, but then we saw these pulmonary nodules on his CT scan, and we're thinking, wait a minute, does this guy have an infection? Does he have some kind of metastatic disease? Does he have lung cancer? Does he have some chronic condition that we're not privy to? And is that white count and all those labs truly attributed to the abdominal situation, or is there something else going on? And we had to also think about his pulmonary function as he was potentially having surgery. So what we saw in the CAT scan, as indicated, was small bowel obstruction, chronically dilated small bowel with the evidence of the thickened small bowel wall, microperforation, and fluid collection. So we did fluid resuscitation pretty aggressively, and we started him on antibiotics. And then the question mark that we posed to the entire team was, what do we do next? Do we go to the operating room once he's resuscitated and resect all of that diseased bowel? Do we put him on medical therapy? He hadn't had anything for 50 years. Would he be a candidate for steroids or biologics? And if we were going to do surgery, when would we do it? Should we do it, the following day after he came in, or do we figure out a time that would be optimal for him?
So this is usually when we would get the call as gastroenterologists that you have this consult. I'm just going to take a poll of the audience in the room here live. Who's thinking medical therapy? Get him ready for anti-TNF or other biologic, or give him steroids. Raise your hand. We have a few. I think colonoscopy could be reasonable. If he hasn't had one recently, it might help identify what some of these strictures look like endoscopically and try to tease out how much active inflammation is present versus how much chronic irreversible fibrosis. But I want to take you through a couple of the ensuing slides to talk about predictors of surgery and how we can tell right off the bat that this patient probably needs to have an operation. I don't disagree with the idea of medical therapy, but maybe not yet, or not as the first intervention. So maybe we can trade, and I'll walk through the next few. So the idea of predicting surgery in small bowel Crohn's disease would be very helpful if we had good predictors, so we could try to counsel patients about your likelihood of needing surgery and the reason why we need to do it now or in the near future. So I wanted to share this study from the University of Michigan, which looked at factors predictive of surgery within 2 years of being hospitalized for small bowel Crohn's. So this patient's now in the hospital, has small bowel Crohn's, so he would fit into this group of patients that are being described. So they looked at over 200 patients who were hospitalized over an 8-year period, and a third went on to have surgery within the next 2 years. And predictors of needing surgery, only 2 came out of multivariable analysis. Having a dilated small bowel greater than 3.5 centimeters was the strongest predictor. We call this pre-stenotic dilation. It's the lake that forms upstream from an area that's chronically strictured. If there's one thing you take away from my part of the presentation, it's this. When you see a patient with pre-stenotic dilation in Crohn's, they're probably going to need to have surgery if they have obstructive symptoms. That's probably not going to be reversible with medical therapy. There are exceptions to the rule, and we'll go through some of the nuance, but pre-stenotic dilation is a marker that I use in my practice when counseling patients that, you have this indicator that suggests a high risk for surgery, especially if you become symptomatic. The other thing they teased out was new to me, this idea of a platelet to albumin ratio. And I've never used this in clinical practice, but it gets at the balance of inflammation burden versus fibrosis burden. And if you have an elevated platelet to albumin ratio above 125, which our patient does, there's also a higher risk of needing surgery within the next 2 years. So our patient has both of the predictors from this study. And other studies have looked at the idea of predicting surgery in Crohn's, and they also reinforce this idea of pre-stenotic dilation, stricturing or penetrating phenotype, and age less than 30, which our patient had initially with his first surgery. So then the question comes up about medical therapy. Are any of these patients salvageable with starting biologics? So this study looked at another cohort of 240 patients with stricturing Crohn's who had a CT or MR enterography, and half of them needed surgery within a median of 1 year. And the group tried to develop what they call this stricture severity score, which were markers from the CT or the MR. And you see in the box the components of the score, having a fistula, being obstructed, again, that proximal dilation more than 3 centimeters, having an abscess or mesenteric stranding. And the area under the curve was 0.7 for predicting surgery within 1 year. And only one group benefited from starting biologics, and it was the group that didn't have any of these factors. So if your score was 0, you see the red line and the figure on the left, very few of those patients needed surgery when they went on to anti-TNF therapy. But if you had any of the factors, and our patient has multiple, if you look at the curves on the right, even starting a biologic, which back when the study was done in 2012, the only biologic was anti-TNF, you're really not moving the needle. These patients are still ending up having surgery. So I would predict, based on what we've learned so far, this patient has a high risk of needing surgery, and I wouldn't be jumping to the biologic therapy, especially with his age, his frailty, and those pulmonary nodules that might be infectious. Elizabeth, did you have any comments about some of those data?
Yeah, I think that you hit on all the topics that we were concerned with. This looked like a chronic situation, and we were concerned that medical therapy may not be able to reverse the chronic, fibrostenotic lesions that you're seeing, and so we're just going to be wasting our time and potentially putting him at harm's way.
So the other issue when I heard about this case was the abscess. We talked about the stricture and the dilation, but he also has a microperforation and an abscess. So this was an interesting area of overlapping management for the two of us to talk about, was how do you manage an intra-abdominal abscess in Crohn's? Does this mean everybody needs surgery, or are there some patients who you might be able to actually treat with medical therapy? So the two tables here highlight the differences in the type of patient who gets by with medical therapy and the kind of patient who needs to have surgery. So our patient is looking more like the box on the left. Ileal disease, prior surgery, long-standing disease, so you're presenting not with a new diagnosis of Crohn's and an abscess, but you've had existing disease for more than a year. Malnourishment, being on steroids, having multiple or multilocular abscesses, fistulae, larger abscesses greater than 6 centimeters, having that pre-stenotic dilation or pretty thick bowel wall. Contrast this with the patients who do okay with medical therapy, someone presenting with a new diagnosis of Crohn's with an abscess, the absence of that pre-stenotic dilation, a small abscess, less than 4 centimeters, no prior surgery, inflammatory phenotype. These are the ones you're thinking treat the abscess and then start a biologic medication. So I wanted to present briefly from the last few DDWs. There was a group in France presenting about this topic of intra-abdominal abscess. And the caveat here is you have to look at their patient population. This is a very highly select group, which is not the patient we've just presented. And their point in studying this highly select group is that maybe you can avoid surgery in some patients with a Crohn's-related abscess. So this group is in France, multi-center, prospective, 117 patients presenting with an abscess. Most had small bowel disease, half had a fistula, and they're young, and the median disease duration is only 2.5 months. So these are mostly newly diagnosed patients coming in with an abscess. The abscesses are small, 2.5 centimeters, not the large abscess in this case. They didn't tell us about pre-stenotic dilation, which we know is a very important predictor. They only drained 9% of them percutaneously, which speaks to the small size. Most actually did okay just with antibiotics for a mean of 21 days. And then they did a repeat enterography, and if the abscess had resolved, they then started the patients on adalimumab. And the endpoint they were interested in was success at 6 months, which was no resection, no abscess recurrence, no steroids, and no clinical relapse of their Crohn's. And 71% met the primary endpoint at 6 months. Less than 10% had another abscess, less than 10% had surgery. And just this year, they presented their long-term outcomes, which look pretty good. At 1 year, 66% met the primary endpoint, only 15% had surgery. At 4 years, only 25% had surgery. But they then shared their predictors for risk of surgery, and anything that was big enough to need drainage percutaneously, anything, abscesses that required percutaneous drainage were associated with the risk of recurrence and a risk of resection with a very high odds ratio. And then that pre-stenotic dilation shows up again. If you're dilated more than 3 centimeters, that was associated with the risk of failure. And if you had primarily inflammatory looking features, that was associated with biologic success. So there was a helpful algorithm that was published about managing an abscess that I thought would be helpful to share. We focused on the initial management of antibiotics, hold the steroids, hold the immune suppressants if they're on it, support their nutrition, and get it drained. But then you have to figure out, are you going down the path of medical management or surgical management based on these predictors that we've reviewed? So our patient is over here in the red with long-standing disease, strictured, prior surgery. So we're thinking that he's going to need an operation after we optimize his nutrition. And then based on whether or not the abscess is fully drained, decide whether he needs to be diverted to heal or whether he can have a primary anastomosis. So I'm going to turn it back over to Elizabeth to see what happened.
So at first, we did the IR drainage of the collection, and this grew out Enterococcus and Candida mixed flora, and we initiated antibiotic therapy. And then given all of this information that was relatively overwhelming, telling us that he would need surgery, we started to plan for surgery, and we also had to plan for when that was going to be. And so, I guess we jump into this slide here, but when we were thinking about his surgery, one of the big things was knowing where he was starting. He was starting in a very malnourished and a fragile state. And that was both from his fitness as well as his nutritional composition. And something that Ryan and I talked a lot about was, some of these patients who've been just limping along have not been taking in good oral intake for a long time, that when we initiate nutritional supplementation or rehabilitation, they can be at risk for refeeding syndrome. And I've seen that in patients who have been really just drinking their food for weeks, if not months. And we have to be really careful in those patients when we initiate either TPN or oral intake, that they can be at risk for that. And so he was showing us so many frailty factors, his fitness, pulmonary situation, his nutritional status, that we knew this was not going to be an easy thing for this gentleman to get through. And so I will let Ryan speak on IBD surgery in the elderly, but long story short is that patients who are older, they do worse than patients that are younger, and they're also prone for complications. And so really, I would say the gestalt here is that you have to prehabilitate these patients. That's a really big focus of surgeons in the past 5 to 10 years, is not just rehabilitating someone after an operation, but what do we do to get them readier for an operation? And this sometimes is possible, sometimes it's not. Obviously in an acute setting or in a patient who has cancer or an obstruction, you don't have that opportunity. But in this gentleman, he was showing us enough that he was going to be able to have some element of prehabilitation, and that's what we really wanted to focus on, is to get him readier for surgery so that when he had his operation, he had the best shot at making it through without an infection, without a complication, without a mortality, to be honest. This is a patient I get very afraid of that might succumb to a pneumonia post-operatively. Urosepsis could bring him down, so we had to do everything in our power to ready him for the operation.
Yeah, I think this is a good point, that for Crohn's, you can often take your time. He wasn't dying of sepsis, he was on antibiotics, he had a percutaneous drain, so the infectious risk was mitigated. Now you have time to focus on the nutrition and do an optimal surgery. With ulcerative colitis, on the other hand, I don't want you to walk away with the wrong message. Acute severe ulcerative colitis, there's a real risk with waiting. You have to decide early in those cases who needs to go to the OR and go. But with Crohn's and a patient like this, you can take time. And we don't have to go through this slide. It's been up here for you to take a look at. The point is that older people, defined as over the age of 65, have worse outcomes when they have IBD surgery, whether it's for Crohn's or ulcerative colitis. They're hospitalized for longer, they have higher complications and higher death rates. So anything you can do to optimize them beforehand is beneficial.
So one of the things we use in our surgical practice is the American College of Surgeons, basically a surgical risk calculator. This is where we enter data about a patient, and then it gives us a grid or a chart indicating what are the chances this patient will have a minor or major complication, what's their risk of death, what's their risk of a venous thromboembolus, a risk of surgical site infection. And so we enter the data that can range from their age to their BMI to comorbid conditions like diabetes, hypertension, cardiac disease, anticoagulation use. And so we put that in there for the gentleman, and I don't have the grid that we populated, but his risk of a substantial problem, a major complication, was about 45. So at the time we met him, the chances of him having a major complication was already half. So we knew we had this prehabilitation to do to get him better. So we focused on that. For the next 3 weeks, we put him on TPN, and we had some change in his pre-surgical labs from the time of the emergency room to when we brought him to the operating room. His white count went down to normal. Albumin didn't budge much, 2.4, but his pre-albumin, this is the thing I want to emphasize more. I am more focused on the acute nutrition as opposed to the chronic nutrition in a patient like this. We want to know weeks leading up to surgery, what has his nutritional supplementation been? And in this scenario, this is a substantial leap from 8 to 20. Creatinine normalized, and his lactate was normalized soon after resuscitation. And so we had a comprehensive discussion, the surgical team, about what we're going to do. And we talked about resecting. We talked about, should we do strictureplasties in this gentleman? Should we strictureplasty one of the strictures, or all of them, or none of them? And if we were going to do an anastomosis. There can be risks of creating a stoma, especially in elderly gentleman who was very fragile in terms of his kidney function. If he has high volume output with an ileostomy, he could end up back in the hospital with acute renal failure. So all of these things were being discussed, and we came to a consensus that the time was now to operate, and we had our woundostomy nurse come and see him. And so this is a classic picture to see in the chart where we're planning for a possible ostomy. We're not certain if we're going to do it, but we want to know where would those optimal locations be. And this is an area that many people don't focus much on and is relegated to our ostomy continence nurses, is Where are we going to site the stoma if we do it? Because we know that patients who have to have an ostomy for a temporary period of time or permanently are at risk for ostomy-related complications, and that can be just purely not being able to have a bag adhere to the skin. And so we site a patient both in the laying down, supine, sitting, and standing positions. We want a stoma that they can pouch on their own, they can be independent with. So this is a really key component to our preoperative planning, is knowing where we potentially are going to put an ostomy. And you can see his prior laparotomy scar in this picture. Oops. And we did an exploratory laparotomy, and we essentially did one large resection of the site to the right that you see. The old anastomosis was strictured, and the whole portion of the bowel that you see there was thickened. And then we had that chain link, basically, of sausages appearance with the saccular dilatation and strictured tissue in between that really gave me the sense that this is not a good candidate to do a strictureplasty on. So we have certain criteria we use when we're thinking about a strictureplasty, and one of those is multiplicity of strictures within a short distance of bowel. It's much better when there is more space so that you can actually perform the strictureplasty. So this would not allow us to do that in this setting. The length of the stricture when they are singular is not so much of a factor. We have lots of different ways that we can do a strictureplasty for short strictures, for long strictures. There are strategies for those that are 10 to 15 centimeters, 15 to 25 centimeters. We have that capacity to do it. But in this situation, it wasn't the right thing. And the other thing I was most worried about with strictureplasty and potentially an anastomosis was his nutrition. So in a situation like this, the nutrition has to be at the forefront. His prealbumin was better, it was acceptable, but it was not great.
Did you see any other areas of active disease, or
not in the rest not in the rest of the small bowel or the colon? Honestly, that was really an isolated stretch, albeit it was a long stretch, but there were no other skip lesions beyond the section that we resected. And you can see here, basically clamshelled open the specimen, really classic findings of Crohn's disease with thickened bowel wall, creeping fat, this pre-stenotic or pre-stenosis dilatation that we're talking about of the bowel is classically emphasized here by the red arrow. And these are some of the findings that you see on a scan, and you say there's just no way this person's going to avoid an operation. We're going to have to do something. And a more up-close look of the stricture here. They have a toothpick to kind of stent it apart, but the pathologist did a great job of photographing the specimen, where you see ulcers in the stenosis to the right, and then you see this very thickened stricture. There's the ulcers.
So that presence of ulcerations makes an interesting point. Kind of makes the point that any stricture is some component of it is fibrotic and some component of it is inflammatory. We often think of strictures as just two kinds. They're fibrotic or they're inflammatory, but in reality they're both. So if you were to do a colonoscopy on somebody with a stricture, you're probably going to see some inflammatory changes or some ulceration. But if they're really narrow and they have pre-stenotic dilation, just the fact that they have visible ulcerations doesn't necessarily mean there's active reversible Crohn's disease. Any stricture is going to have some of both. So this is just a good illustration of that you're seeing ulcers on pathology, but this guy needed to have surgery.
Right, and here's the picture of the low-powered view of the Crohn's disease area with ulceration. And you see this chronic active inflammation and classic pyloric gland metaplasia. And here's the stricture again, and we're going to show you this for a particular reason. We did some cross sections through the stricture, and we found mucinous carcinoma. So as if we didn't have enough wrinkles to the story, right? So we're brought back to that CT scan of the chest, and we're thinking, boy, does he have metastatic small bowel cancer in the setting of chronic Crohn's disease? We wouldn't have any indicators, on his exam that it was a cancerous lesion. And so that was a surprise when we found it, but not really if you think about it, because the people that develop cancer in inflammatory bowel disease, or at least in Crohn's disease, are commonly ones who've had inflammation for a long period of time. And so we're really getting the sense that this gentleman is one of those people that could have a cancerous lesion. Here's the final pathology. Invasive adenocarcinoma, poorly differentiated, signet ring cell morphology. He had lymphovascular invasion. He had 0 out of 9 lymph nodes, so at least he didn't have nodal disease. Surgical margins were negative, and MMRs all intact.
I wanted to ask about the size. Is that a typo, or was it truly 15 centimeters diffusely involving that abnormal small bowel?
I think it's this whole section here. I mean, it was hard as cement, and you know, something that had been growing for so long, and this patient truly had been limping along, and lo and behold, he'd had a cancer growing this whole time. So that was alarming, and that was a hard conversation to have with him after we got through all of this. Is now we have another, you know, chapter to your book. Here's his post-operative photograph. While the stoma is a little swollen, this is actually a really nicely situated stoma, and I take a lot of pride in this, by the way, because we have the opportunity to make ostomies that are perfect for a patient. In this situation, we really had that opportunity. We want an ostomy that has height. An ileostomy should be at least 2 to 3 centimeters in height. It should be symmetrical. We should have a centralized os, as you see here, and the patient should be able to see it, and it should be within the rectus. And so it fits all of those criteria. And I say that because we don't do a lot of ostomy education. And this is an area that I spend a lot of time with our residents, because surgeons can make good stomas when they know how to make good stomas, and we have to keep educating our residents on that. So any comment on that, or should we tell them the follow-up? What happened?
I have not seen a small bowel adenocarcinoma yet in my practice, but it's sobering. This is the kind of patient where you're going to see it, the long-standing ileocrohn's, poorly controlled. It's an inflammation-related cancer. So I feel good about the decision to have surgery and get this while you could get it.
Right. And so he had a very high output stoma afterwards. This is classic. It's like a post-obstructive kind of bowel diuresis, if you think about it. He's been obstructed for so long, and then everything kicks into high gear, and has, you know, unobstructed bowel. And so we needed to start him on daily fluids. He had a heavy resuscitation, also loperamide, to keep his ostomy output to 1,200, under 1,200 milliliters a day. In fact, we sent him home with a PICC line so that we could continue his fluids at home. And interestingly, he's never been readmitted. Despite all of this, he never got readmitted. He never developed a surgical site infection. His nutrition has only gone up and up. But we doubled back on his chest CT. In fact, we got the pulmonologist and the thoracic surgeons involved because we were worried, is this metastatic disease? And he did have this history, as I mentioned, of mycobacterium, and they did a CT-guided biopsy of this lung lesion, and it was consistent with MAC. So lucky for him, this was not metastatic disease. So his stage of the disease, I believe it was stage 2, really no indication for chemotherapy, surveillance alone. So he would have imaging every 6 months. And as far as I know, he moved to Washington to live with his son, and he is seeking reversal of his ileostomy in the next 6 months. And so we'll see if he becomes a good candidate for reversal, because that's a whole nother conversation about when is a patient ready for that.
So we are coming up against time, and I want to make sure we have some questions. So I'm going to show a very brief series of slides about the safety of doing surgery on biologic therapy, because this, I think, is a very clinically relevant topic, and then maybe we can pause and have some interaction with the crowd. So DDW, the last couple of years, has informed the question of what happens when you operate on our various different biologic agents. And this is probably the most important study of the several that I'm going to show you, the Puccini trial. I'm not sure why it's not been published yet. I don't know if that's a red flag for some kind of methodological issue, but it's been presented only at DDW in abstract form. It was a huge prospective trial that was recent, 2014 to 2017, 17 centers looking at IBD patients undergoing major intra-abdominal surgery on anti-TNF. And they looked at several groups, anti-TNF exposure within 12 weeks of surgery, detectable perioperative anti-TNF drug level compared to patients with neither of those two factors. And they have almost 1,000 IBD patients undergoing surgery. 40% pre-op anti-TNF within 12 weeks of surgery, 25% had a detectable peri-op drug level, and you see in the figures that there was no increased risk in any infection related to TNF exposure compared to unexposed, and no increased risk in the frequency of surgical site infection based on being recently on an anti-TNF. So the conclusion is, at least from the standpoint of infection, no big deal if you have to operate with an anti-TNF on board, and there's no need to stop it and have washout and delay an otherwise necessary surgery, especially when our drugs have long half-lives and take 3 to 5 half-lives to leave the system. You're talking about, waiting 2 months for the drug to be gone, and it's not a reasonable reason to wait given the lack of increased risk of infection.
This changed the way that we practiced this data. I don't stop biologic agents before surgery. We continue them right through and even give them their injections before they leave the hospital. So that's different than when I trained. We were worried. You did the washout, you waited a month, you tried to find the ideal time to operate, and it was not necessary.
And these slides I'm not even going to read. Basically, they say the same thing. Vedolizumab, no increased risk of infections. Tofacitinib, no increased risk of infections. And I don't have a slide for ustekinumab, but that was presented this year at DDW, no increased risk of infections. So for all available classes, operate when you have to operate. Just so you can answer your question in the post-test, I threw in the AGA guidelines for post-op surveillance. So for a patient like this who's now in surgically induced remission, what do you as the gastroenterologist have to do moving forward to prevent the mishap of his first go-around with surgery where he didn't have any follow-up? You have to decide, are they low risk or high risk for recurrence, knowing that most people will recur. And he's older. This was his second surgery, so he kind of has some low-risk features and some high-risk features. I think the fact that he has an active small bowel cancer puts me in the category of someone I'm not going to immediately start on biologic therapy, but I will want to do a colonoscopy 6 months later to see if his Crohn's is coming back. So what the AGA suggests is use early pharmacologic prophylaxis over no prophylaxis, which in this case we're going to go against the AGA guidelines. We're just going to watch. Use anti-TNF or thiopurines over other agents, but there is some emerging data from this year's DDW that vedolizumab and ustekinumab also have benefit in post-operative Crohn's disease. So I think the message here is probably going to be use any biologic to reduce the risk of post-op recurrence, but don't use 5-ASAs, budesonide, or probiotics because they don't work for post-operative recurrence. Regardless of your strategy, whether you're watching and waiting or actively treating, do a colonoscopy 6 to 12 months later to assess whether the patient's recurring and whether you need to adjust your therapy. And how do you decide whether to start therapy or adjust? You should become comfortable with the Rutgers score, shown here. You stage the Crohn's at the anastomosis on a scale of 0 through 4. 0 to 2, which is no lesions or minimal lesions, they really don't have significant long-term recurrence. Those are patients you keep on their current therapy or you keep them on no therapy. If they have a score of I2, I3, or I4, then you want to start them on treatment or optimize your current treatment. So this is Miguel Reguero's slide that I'll just leave up for how he does post-operative Crohn's since he's the guru. And we'll pause there, and if it's okay with you, Elizabeth, we'll skip the second case.
We can.
And see what the audience has to say. Thanks.
Yeah. I think we just had too many slides. We're too eager.
Great.
Patients.
Thank you both. So go ahead.
So this patient has small bowel disease and has stricture and developed small bowel cancer. We do surveillance with colonoscopy, but how can you detect small bowel cancer? In a patient with stricture disease, you cannot do capsule. And if you do capsule, you see an ulcer, you don't know if it's from Crohn's or it's cancer. So any way to detect early cancer in the small bowel?
There's not a good screening tool available. I would say that if you're doing regular colonoscopic follow-up, which he was lacking in this case, you want to biopsy strictures to look for any sign of cancer. But if the stricture is progressing and the patient's not getting better, recognizing when you need to operate. Primarily, small bowel cancer gets diagnosed surgically when you're operating for an obstructing stricture. So not delaying a necessary needed surgery for too long can help you make this diagnosis. There may not be a good way to screen for it or detect it non-surgically.
Great. Go ahead, Eric.
Great talk, guys. I have a question one for each of you. For Elizabeth, in terms of this prehabilitation that you preach for these certain patients, what is the sort of time frame? Because, in this patient, it sounds like 3 weeks was the case, but in terms of what is are you tracking the pre-albumin and seeing where that goes, and then you're saying, okay, time for surgery, or is there sort of a...
Right, so we follow them weekly, and they have labs done weekly and visits weekly, because a patient like this is at high risk for readmission for an obstruction or for potentially even sepsis, right? Because he's already perforated, he had a drain in. And so we need to follow them closely, but have a very low threshold to proceed to surgery if he shows us things that he's declining. Like if his nutrition does not improve despite all of these efforts, or his sepsis does not resolve, we have to do something, and under less than ideal circumstances, we would have to operate. But what Ryan is saying, and I agree, is that Crohn's in some scenarios is not an emergency. And that was our residents running like, we got to book the case now, we got to go. I think what we have to look at it a little bit like is how we manage acute perforated diverticulitis. If we have a localized perforation, we're not going to the operating room immediately with that. We are draining, we're resuscitating, we're using antibiotics, and prehabilitation, which is a multifactorial, or it's got many steps to it, including physical therapy all the way to smoking cessation. But we need to be mindful of that and use it when we can. And when we can't, you're right, you just go to the operating room. But in this scenario, this is what I want our residents and our colleagues to recognize, is we can do better surgery on patients if we can improve their standing situation. This is a gentleman who just had no medical care and no support for so long. That initial treatment is going to start in the emergency room, and it took us about 2 months to get him through this whole thing. So,
great. And Ryan, thanks for bringing in all the sort of the guidelines and the pathways, the algorithms. I think it's very helpful, especially in these sort of complex patients. Help us sort of have a guide to follow. In your patients that have an abscess that's too small to be drained, or it seems like the guidelines suggest you can start medical therapy. Starting antibiotics and then starting therapy, do you re-image to make sure the abscess is gone before starting biologic therapy, or do you start concurrently once you start antibiotics? What is your sort of approach to that? Yeah,
for the patient who is newly diagnosed and small abscess and it's not drainable because it's so small, I would start with antibiotics and no steroids, no biologic, just antibiotics. I did this recently with a 20-something-year-old patient in my practice. She presented with a 4-centimeter abscess, new onset ileal Crohn's. She was started on steroids in the hospital, so we tapered her off. I had her meet with infectious disease, and in tandem, we decided what antibiotics to use, when to re-image, and we talked to her about anti-TNF therapy and had her all on board, ready to go, once we knew that the abscess was headed in the right direction and we wouldn't need surgery. So she was on antibiotics for about a month. She had several MR enterographies showing serial reduction in the size of the abscess, and when it got down to below 1 centimeter, we started her on infliximab, and she's now completed induction, the first maintenance dose. She's doing really well. Her inflammatory markers are normal. She has no symptoms. We had another follow-up scan showing the abscess is basically gone, and she's, I think, going to be a success and avoid surgery. So it can be done, but you have to know your patient. If it's a large abscess or long-standing disease, these are all factors that should be pushing you more in the direction of surgery first.
And the question about why is a 6-centimeter or greater abscess, a patient more prone to have, need to have surgery down the road, I don't exactly understand that, but I suspect it might talk about the size of the perforation, you can have a 6 centimeter abscess and it's just been there for a little while and it's grown to that big, but you can also think of the area where it perforated the bowel is larger, and so that patient is going to be more prone to continuing to feed that abscess collection like a fistula, the contained fistula. So that's the only reason I can think that the larger abscess, because we drain big abscesses with diverticulitis all the time, and those patients do go on to need surgery. But the size of the abscess, whether it's 3, 6, 8, that doesn't really tip us towards them having to have any emergent surgery. We do the same thing either way. We'll drain them, resuscitate, improve, and then assess for surgery.
Thank you. Great. So maybe we'll end. Oh, go ahead, Tom.
I see this occasionally where someone has miliary chronic anastomosis, and let's say they have this dilation of 3 centimeters, and there's a relatively short stricture. Based on this, it would seem like the dilation is just a temporary. If they ask you to dilate it, is it just a temporizing? It's not going to really alter your need for surgery in the future, because an endoscopic dilation really can't do much. Do you still recommend trying to open these people up if they have this pre-stenotic dilation and they're not responding to all the other drugs? Is it really beneficial to put them through the risk of perforation and complication from that?
So, sometimes it's the patient's reluctance to have surgery. And so they're looking for what other option do I have besides having surgery, because kind of the numbers that I quote our patients is once you've had a first surgery, you get about a 33% chance of having a second surgery. Once you've had a second surgery, you got about 50% chance of having a third surgery. And those numbers kind of creep up. And so there are many patients who try to slow play what's going on. And so an endoscopic dilatation usually will make something slightly better, but I don't think it ever fixes the problem. And the medications can't fix something that's truly stenotic. So when we fracture with a balloon and we make some, micro, changes to the diameter, I think in the long run it ends up kind of stricturing down again. It just depends on what the patient's able and willing to live with from a symptom standpoint. Because usually something that's several centimeters wide, they can have okay GI function, they're just not feeling normal. So a lot of it's just patient tolerance.
I'm sorry I didn't include the slide on balloon dilation. I was going to put this in, and your question suggests I should have. The data are decent in the short term for endoscopic balloon dilation. If it's a short anastomotic stricture, if it's less than 5 centimeters, if it's only one stricture, you can have good technical and clinical success with endoscopic dilation. And it usually kicks the can down the road for a number of months, that the patient feels better, but then, to Elizabeth's point, their obstructive symptoms come back. So I think the role for endoscopic balloon dilation is when now is not a good time for your patient to have surgery, like the patient who has a major life event, graduation for school-age kids. If surgery is going to be poor nutrition, it buys you time in somebody who responds well temporarily to an endoscopic balloon dilation. But the trade-off is a 3% risk of a complication, like a perforation or bleeding, that might then create the immediate need to go for surgery urgently. So I think Europeans are big into balloon dilation, and a lot of the literature comes from European case series. I would guess it's cost effective in the short term, but I tell patients it's usually just temporizing, but reasonable to try for the right patient.
So maybe we'll end with one quick question, quick answer from our virtual participant. This patient had stricturing and severe dilation. Any concerns about prepping and insufflation in this patient?
Yeah, this is a great point, and I should have rephrased when I said this live. The question is how can you do a colonoscopy in this patient without causing severe distension and even worse? If the patient can't prep, or you're concerned that they can't tolerate a prep, you can't do a colonoscopy. So this is a patient where I think the likelihood of being able to do one is basically zero, and that's why we didn't talk about what the pre-op colonoscopy showed.
Didn't have one.
But in patients who are not that obstructed and have not had a colonoscopy recently, I think you could argue that there's some information that you could gain there to try to determine medical versus surgical therapy if you're on the fence.
Great. So thanks, Dr. McConnell, Dr. Raskin.
Thank you.
And so that does it. Thanks for joining us. This was such a fabulous morning. A few announcements as we make our way out of the room. There will be a lunchtime session, I believe, in this room on systemic therapies in hepatocellular carcinoma. So if you're interested, please join us. And we're going to have a few breakout sessions at 2:10 p.m., our APP committee has an ice cream social. So if you're interested in ice cream and networking with our APP colleagues and committee, please join us for that. As you enjoy Monterey this afternoon, please come back at 5:30 this evening. From 5:30 to 7, we'll have a clinical exchange session with light snacks and drinks, networking, visit our booth, our sponsors, so definitely please join us for that. And then finally, at 5:30 p.m. to 6:15, Dr. Marina Reutman and Dr. Ratika Kumari for the GI Janes group has a Women in GI breakout session. So definitely please join us for that as well. So thank you so much and enjoy the rest of your day.